OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Dylan Graetz, MD, MPH, is a pediatric oncologist who received her MD and Masters of Public Health degrees from the University of Connecticut. She also completed a residency in pediatrics at the Children's Hospital of Philadelphia and fellowships in pediatric hematology oncology and global health at St. Jude Children's Research Hospital. As an assistant member at St. Jude Children's Research Hospital, she directs the Culture and Communication Program within the Department of Global Pediatric Medicine. Dr. Graetz conducts mixed methods research focused on how cultural context impacts interactions between pediatric cancer patients and families and their healthcare teams. Through her work, Dr. Graetz aims to understand and enhance communication practices and patient-centered care of pediatric oncology patients in global settings, as well as interdisciplinary communication of healthcare teams. Clinically, Dr. Graetz treats children with solid tumors with a specific focus in renal cancers. The Cloud CME activity code for today's grand rounds is 3224. Please welcome Dr. Dylan Graetz.
Hi, everyone. Thank you so much for having me, and thank you to Dr. Hilton for that kind introduction. Apologies, I cannot be there in person, and very impressed that you all start grand rounds at this time in the morning, and so thank you for joining me. I'm going to speak today about global health and really about health disparities and health equity from a global and pediatric oncology perspective. So this talk is called Promoting Global Health, What Lies Under the Surface, and my hope is by the end of the talk, you'll understand why I've named it that way. So I do receive some funding from the NCI and the Conquer Cancer Foundation. I will present some of the work for which I've received that funding today, but the ideas and findings that I'll express in this presentation are my own and do not represent that of my funders. So my objectives today are to describe the factors influencing health outcomes and identify which are modifiable, to summarize the evolving landscape of global health priorities, and give examples of how modifiable factors influencing health can be examined at least from a global pediatric cancer population, but I believe that the strategies that we've been using apply much more broadly. So we'll start with some definitions and some history, and then talk about the factors impacting global health, global disparities in pediatric cancer, and then what I refer to as the iceberg. And we'll talk about how we are addressing some of what lies beneath the surface as part of that iceberg, including material or financial hardship, stigma, communication, and then patient navigation as a potential intervention. So I just want you to think for a moment about what impacts health. And I'm not sure how interactive these sessions usually are. If you'd like to answer things in the chat, please do. But I'm just going to give you a moment to think for yourselves about the various things that may impact your health, your family's health, the patients you care for. What impacts health? And so as you've taken the last 20 seconds to think about these things, I imagine some inherent biomedical differences have come to mind. There certainly are inherent biomedical differences, and in cancer, we know that there are genetic factors that do drive disease. That said, there are also socioeconomic factors, health system factors, environmental factors, access to care, belief systems, among many other things that I'm sure you have all been thinking about. And most of these are in some way modifiable. And so the big aspects of our lives that influence our health and the health of the patients we take care of, most are modifiable. And I see some great things in the chat. So thinking about what impacts health, traditionally, we've thought about social determinants of health, and those are measured on an individual patient level. I'm not sure what electronic medical record you all have, but in Epic, which we use, you can actually document some of these social determinants of health, and they generally include economic stability, which is things like income and job security, education and education access, the neighborhood and built environment, the social community, and then healthcare access. And another way we can think about this is as a set of concentric circles, where again, you have the individual at the middle, surrounded by various categories of factors that may influence their health, whether that's interpersonal connections, institutional rules and regulations, community social networking and standards among individuals, or public policy at a health systems level. Health determinants have been studied for a very long time. So one of the first places we see this in the literature was in 1842, a report out of Great Britain, which was a discussion of the sanitary conditions. And then just before the turn of the century, you saw literature start to come out of the US. One of the first publications here was from Du Bois et al. And you can see that in the US, race was a factor very early on. In the 1940s is where we saw the WHO and the United Nations General Assembly start to come together around universal human rights and some of these health determinants. And you can really see that from about the 1990s on, there's just been this explosion of literature related to health determinants. And I will say that this graph does not include a recent peak that we saw after the summer of 2020 and George Floyd's murder, but it also doesn't include a decline, which I imagine is coming in the upcoming years, related, at least in the US, to some shifts in our administrative policies and priorities, as well as funding opportunities. But when we really think globally, prior to 2000, much of the work on health determinants was being done on a country-by-country basis, potentially with partnerships, but often those partnerships were one-on-one. And in 2000, the UN General Assembly came together and adopted the Millennium Declaration. And this was a global partnership of countries committed to these 8 voluntary goals. And the idea was that these goals would be achieved by 2015. And so, as you can see, quite ambitious: to eradicate extreme poverty and hunger, to achieve universal primary education, to promote gender equality and empower women, to reduce child mortality, so there we see our pediatric population, to improve maternal health, to combat HIV, AIDS, malaria, and other diseases, to ensure environmental sustainability, and to develop a global partnership for development. And from 2000 to 2015, a lot of progress was made. Overall, we saw a 50% decrease in extreme poverty and large improvements in malnutrition, particularly in children under 5 years old. And goal 4 was really focused on under 5 mortality. We saw improvement in education, particularly for women, and we saw big impacts on water and sanitation. We also specifically saw huge benefits, huge strides in HIV, tuberculosis, and malaria, which were major foci of this initiative. And childhood mortality, which I believe I mentioned, fell by 50%, a lot of it due to those conditions, but also malnutrition. So while these were really ambitious goals, the Millennium Declaration was more influential than anything had been prior to this. However, there were limitations and disparities remain, and we actually saw some disparities heightened during this time, partially because in some ways, unintentionally, this encouraged vertical systems. And so, for instance, lots of programming related to HIV/AIDS or malaria, but other things getting left out, huge strides in sort of middle income countries, but maybe less resources dedicated to the lowest income countries. So in 2015, a new development agenda was adopted, and that included the establishment of what are called the Sustainable Development Goals. And so here the target has been moved to 2030. And as you can see, there are many more. So we've gone from 8 to 17, and they're much broader. And so it's a broader range of economic, social, and environmental objectives, with more of an approach to strengthening health systems, again, thinking perhaps less vertically and more horizontal, and really being adaptable in our planning so that it's not a one solution fits all, and that we have strategies for various resource levels. So that's global health. a little bit more broadly. Again, this is a bit of a whirlwind from health determinants broadly to global health, and now I'm going to take you to pediatric cancer. But my hope is that this has set the stage. And as I just described, child health has really been a focus since the early 2000s, but most of that focus has been specifically on maternal child health and some of the communicable diseases we mentioned. That said, there are over 400,000 projected cases of childhood cancer annually between now and 2030, and that number continues to grow. And what you'll see on these graphs is a huge gap between the children that get diagnosed and the children that we know from modeling are predicted to get cancer. And because of the huge gains we've made in treating and curing childhood cancer, the cumulative global burden is even greater because you have these children now surviving their illnesses, which is fantastic, but it means that there are even more children to care for. And so, again, on the left, you see the projected annual cases, and on the right, the cumulative global burden. And most of these children live in low and middle income countries. And on this side, what you can see is that in blue, so to orient you a bit on the bottom, you have various continents or regions, and they sort of go from lower income to higher income. And so that blue line demonstrates that childhood cancer incidence is going up. And that is really, as you see on the left with that gap, about detection. And so it's not necessarily that we think more children are getting cancer in high income contexts, but that they're being diagnosed and that they're not dying early of other things. And that's really what you see in red. And so you can see as income level increases, red represents childhood mortality, all childhood mortality under 5. And as income increases and healthcare resources increase, that goes down. But then what you see in sort of that yellow or green is that childhood cancer mortality is actually highest sort of in the middle, where you have less under 5 mortality. And so children are surviving some of the childhood illnesses, but then you do not have the resources to treat cancer. And so you get a peak in mortality in these middle income countries, and you can see how broad that is. So at St. Jude, we cure cancer at over 80%, and we're very proud of that. But globally, the estimated net 5-year survival for children with cancer is still under 30%. And you can see there with the colors how big these disparities are worldwide. So again, just to emphasize, it's really flipped. Here in the US, 80% of children with cancer will survive. And in low and middle income countries, 80% of children with cancer will die. And those are the children that we are able to detect. So as I've mentioned, close to 400,000 children will develop cancer worldwide, and over 80% of those live in countries with limited resources. And in those settings, most children die. This morbidity is multifactorial. It includes access to care, treatment abandonment, which we'll discuss a little bit more later, delayed diagnosis, the quality of care, and the health system infrastructure. And so in September of 2018, which was just around the time, as we've discussed, that we were switching sort of from the Millennial Development Goals to the Sustainable Development Goals, St. Jude became the first partner with the WHO for childhood cancer. And together we launched the Global Initiative for Childhood Cancer. And the goal of the GICC, or the Global Initiative for Childhood Cancer, is to increase survival everywhere to 60% by 2030, which is a huge, ambitious goal. But I think you've seen now that these tend to be quite ambitious goals. And that would save over 1 million children with cancer in the next decade. And so we're doing this by focusing specifically on 6 index cancers and by using this cure-all framework. And so you can see that the cure-all framework is really about much more than tertiary treatment centers. It is about thinking about centers of excellence and care networks, including referral systems and how to get children to those places. Also about universal health coverage. Cancer treatment is very expensive, and we know that the cost of therapy is a reason that some children do not complete therapy. And so thinking about universal health coverage, thinking about regimens for management. And again, these need to be context appropriate. So what you might treat a child with cancer on is going to depend on the quote unquote evidence, correct? But a lot of that evidence comes from high resource settings that may be very different contextually from where those regimens are being administered. And if they are not adapted and sort of context considered, then we may do more harm than good. And so what we've seen historically is there is a tendency in some settings to overtreat. And so we know that the therapy that we use for cancer, chemotherapy, radiation therapy, surgeries, can be highly morbid. And we want to make sure that the settings in which we're administering these treatment have the appropriate resources to support the children and that we're not creating undue toxicity. And so we have seen children die from toxicity rather than from their disease, and trying to manage that and balance that involves really rethinking the regimens with which we treat children. And then, of course, evaluation and monitoring, thinking about quality assurance and robust information systems to collect our data. There's also a huge component of advocacy, and this happens at a local, regional, national level. You've seen many national cancer control plans recently, and so childhood cancer really being integrated into the health policies for a country, leveraged financing, and then linked policies and governments. And so in governance, and that's how you get cure all. And so to delve a little deeper, some of the core projects involved in the cure all framework include the analysis of the cancer health system. I just mentioned the National Cancer Control Strategy, and so trying to advocate for and implement national cancer control plans that include childhood cancer. Implementation of a cancer workforce, so treating children with cancer requires a very specialized workforce. Thinking about national networks and referral pathways, so again, getting these children to the tertiary centers. Defining national standards and guidance, especially for these 6 index tumors that I mentioned. Thinking about essential medicine. So the other reason you need to context adapt strategies is that you cannot suggest somebody treat someone with a medicine that they do not have available. And so thinking about an essential medicines list, and we've recently launched, again, in collaboration with the WHO and UNICEF and many other partners, a global platform for essential chemotherapy. An economic analysis and benefit packages review of cancer, strengthening and linking the cancer registries. Again, I just presented that gap. And so we have a huge problem just with diagnosis and with keeping track of who has cancer and what's happening to those children. So thinking about both hospital-based and population registries, a dashboard for childhood cancer monitoring, and then local and regional advocacy portfolios, including case studies and awareness campaigns. And so what I hope you can see is that we're really trying to work both at that individual level, the hospital, the country, the region, and globally. And we talk about this as sort of a micro to macro system. But again, I hope it's very reminiscent of some of those early slides that I demonstrated. At all these levels, folks are being influenced. Their health is being impacted. And so if we are going to change things, we also need to be working in a multi-level system. So within our program, again, Dr. Hilton mentioned that I direct a program called Culture and Communication within the Department of Global Pediatric Medicine. And we have taken these concentric circles of patient-centered care and expanded it to include the clinician. And so on the right side, you'll see that we as clinicians are also surrounded by our own teams, our resources, and our culture. And we've placed ourselves and that set of concentric circles as a mirror to the patients. And so in 2022, we published this patient-centered care model as something that we thought was applicable globally. And our program and our work really focuses on the interactions where health systems and patients and families are coming together, because we believe that it is by improving these interactions that we will impact outcomes. And again, those outcomes include access to care, quality of care, treatment abandonment, all of which contribute to morbidity and mortality. And so now we'll shift and start talking about that iceberg. And here I present to you the systems thinking iceberg, in which you have certain events that are above the line of visibility. And that allows you, if you're just looking at those, to react to what's just happening. But if you really start to look beneath the surface, you can begin to anticipate by looking at what has been happening, to design better, to think about what might be shifted, and to really transform attitudes, beliefs, values, things that have been sustaining the system to, again, really make systemic long-term change, which is the kind of change that we need and are looking for. And so I'm going to talk a little bit about treatment abandonment, which is a very well researched and thought about topic in pediatric cancer. I will admit that I do not like this term, but it is the term established in the literature. And so for now, we are using it until we can change the literature. But it is properly defined as the refusal to initiate care or discontinuation of therapy for a consecutive period of 4 weeks or longer. And historically, a lot of studies have really focused on trying to reduce treatment abandonment, but they have been focused sort of above that line of visibility. And I think if we're really going to change treatment abandonment, we have to look at the core components, at the major drivers, which include material hardship, stigma, fatalism, a lack of hope, an acceptance of these healthcare inequalities, as well as communication and care coordination. And so I'll start by talking about material hardship and some of the work that we've done there. And when I say material hardship, I mean not only just cost of treatment, but also lack of food, lodging, transportation. And so if it's very difficult for you to get to a cancer center or to stay at a cancer center or to feed yourself at the cancer center because you've had to leave work and your other children and responsibilities, you may not come or you may not stay. And so many institutions worldwide have started to provide some of these basic things. And so for those of you who are familiar with St. Jude Children's Research Hospital, it is a huge part of our mission that families are not responsible for cost of care or while they're being treated, housing or food. And so those are all things that we provide. Similarly, many institutions around the world, including in very low-income countries, are providing these things for patients in order to get them to care and keep them in care. And so when we think about childhood cancer health economics broadly, we have to remember that there were some basic assumptions that childhood cancer was potentially curable, but really too expensive for low resource settings. And so again, in the history of global health that has been focused on communicable diseases, the thought was childhood cancer is just too complicated and it's just too expensive. And too many of those children are going to die anyway. And so it is not cost effective for health systems with so many competing priorities to be focused on childhood cancer. But really, a lot of data has begged to differ. And so there have been a lot of economic evaluations in childhood cancer. In 2012, there was a cost effectiveness threshold analysis that was published. And from there, lots of real world data proving that childhood cancer treatment is cost effective in a variety of settings. And so we've seen multiple cost effective analysis publications from various settings published since that time. And then this work has been expanded to think about cost benefit. And so, okay, it might be cost effective, but just because it's cost effective does not necessarily mean that the benefits outweigh some of your other priorities. And so really starting to think not just about costing, but about a cost benefit analysis and a return on investment analysis, as well as, okay, if we've convinced you as a nation that treating children with cancer is cost effective and is beneficial, and that on the cost benefit analysis, the benefit outweighs the cost, then we really need to be helping think about how to budget for this. And so working on budget impact tools has been some of the most recent work. And this has led to policy impact. It's led to these budgets getting integrated into national cancer control plans and helping countries really think about how they might begin to prioritize childhood cancer or at least include it in the agenda. And it's also helped them think about new benefits packages. And so you can see on the right all of the different levels of baseline treatment, sort of focusing on access or referral, focusing on abandonment, and then comprehensive care and how that increases your survival probability. That said, to date, most of this work has reflected the healthcare perspective. And so again, we're thinking about hospital administration, about institutions, and about government policies and how we can advocate that this is worth the money. But it is not, or has not to date, incorporated as much of the family and patient perspective. And so trying to think a little bit more about the patient or the parent or the caregiver or the family, this is a framework that's been used in adult oncology that considers financial hardship, but in these sort of overlapping Venn diagram. And so you can see that material conditions, which might include out-of-pocket expenses, missed work, reduced income, are there, and near them and somewhat overlapping but not completely is a psychological response. So feeling distressed due to those costs, concern about the wages and income that may be lost, and then again relatedly coping behaviors. So what you might do. So you may take less of your medicine, you may not come to every visit. And so we know all of these things interact, but primarily they've been looked at somewhat separately. And so recently we've been trying to think a little bit more about how this framework might be adapted or apply in pediatric cancer. And we began by reviewing the existing evidence. And so looking at that framework for financial hardship in general oncology, and then looking in the literature at the childhood cancer specific publications on financial hardship. As I've demonstrated, that's been increasing recently. And so we decided to do a systematic review. And as a part of that, we looked at all measurement tools that have assessed financial hardship in chronic conditions and pulled those tools. And so here you can see just the Prisma diagram of our systematic review, including how many publications were identified. We ended up removing duplicates, screening, assessing full texts, and then included about 120 articles in the analysis. And again, what we saw was some discrepancy in what was being assessed where. So there really was not a common approach. And so you had certain items being asked in lower middle income countries and different items being asked about in high income countries. And then this sort of group in the middle where there were some components reported universally. So we decided one of our next steps had to be to offer some normative guidance and to try to standardize across settings. And so in order to do that, we've been taking our systematic review and doing some group concept mapping with various invested partners, as well as mapping of all those individual tools I mentioned that we pulled, and trying to establish domains and different components, as well as a comprehensive question bank. And you can see that as we developed this framework and we included caregivers as well as treating physicians, nurses, different clinicians, the childhood cancer framework that we developed did not directly map to the existent oncology framework. So there was some overlap, but a lot of items that had been categorized one way in the existent framework, our panel really felt like they belonged somewhere else. And so, again, I've now mentioned how we've done this review and we did this process of concept mapping to really start to think about a new framework for childhood cancer. But we also have been pulling all of these tools, and a team led by colleagues at WashU really took all of these different tools, and both the ones utilized in oncology and broadly, and created this organized, comprehensive question bank in which the individual items from each of those tools were pulled and mapped to our new domains. So we included the domains in which they were in originally, but also thought about them using our new framework. And where we plan to go with this is really a methods toolkit. And so we now have a validated framework. We've pulled all of these standardized measures. We're starting to establish domains with the question banks. And And what we're in the process of doing right now is actually coming together around a tool or a set of questions that can be used globally. And so we culled these original items from thousands to less than 50, and are now discussing with various experts through sort of an iterative review how those questions need to be rephrased to apply to a global population. And then we'll go through a process of what we call cognitive debriefing, which I'll talk about. We use some of these methodologies repeatedly, and so I'll get into that method a little bit later, but it's really a way to make sure that the questions, as you've pulled them from a question bank and rewritten them, make sense to your population. So again, this is a toolkit. This is a survey that we hope could be clinically used where somebody, a clinician or sort of anybody working in the healthcare system could meet a family and ask them these set of questions or give them this set of questions to fill out to really globally assess their financial hardship. And so thinking about not only some material facts, and so it does include questions about income, about employment, but also about social support, about coping mechanisms. So everything we sort of saw in that Venn diagram now together and asked in a way that we hope will be globally applicable, locally adaptable, and understood by the populations of interest. And so the next component will be trying to implement this toolkit in various settings. And so now that I've talked about material hardship, I'm going to switch gears a little bit and talk about stigma. And stigma is an area that we've really been delving into recently. And so there are many definitions for stigma. Many of them come from the world of mental health, but the WHO defines stigma as a negative association between a person or group of people who share certain characteristics and a specific disease. And we know from the literature that stigma leads to stereotyping, discrimination, and social isolation, and that it's a barrier to healthcare acceptance in diverse conditions. And so there has been a ton of literature in mental health, in neurologic conditions, in HIV, and in adult oncology. But there are very few studies of stigma in pediatric oncology. And the studies in adult oncology do not always apply because they, for example, will focus on screening or on prevention, which are not as applicable in our pediatric cancer population. And so you see stigma publications surrounding lung cancer and smoking, publications around breast cancer, and around HPV and cervical cancer. That's predominantly where the literature is. And while there are some things that we can take there, for instance, when you think about the appearance-altering surgeries involved with breast cancer, some of that is applicable to the appearance-altering surgeries that come into play with certain pediatric cancers, but it isn't a direct fit, and we'll explore that a bit more later. So when we started this work in 2021, the only existing studies focused on childhood cancer were looking at psychosocial distress in cancer survivors from high-income settings, and specifically Korea, and thinking about the effect of advocacy for overcoming this stigma. But there were no studies formally exploring the impact of stigma on cancer care acceptance or adherence within a pediatric population. And so there really was a gap in the evidence. And when we first decided to look at this, one of the first questions we had was, we know stigma is a social construct, and most of the work that has been done starts off as single site. But pediatric cancer is a rare disease, and if we have to study it in each place separately, it's going to be hard for us to move the needle. And so one of our first questions was, can we look at stigma across cultural contexts? And so we included 3 sites, one in Guatemala, one in Jordan, and one in Zimbabwe. And the aims of this study were to explore the ways in which stigma influenced decision-making in cancer care and identify potential strategies and opportunities to mitigate stigma. And we used a well-established framework. So the health stigma and discrimination framework has been used to study stigma globally in diverse contexts in many different conditions. It had not been used yet in pediatric oncology, but we focused our study around this framework. And these were our methods. So we included adolescents and parents of children recently diagnosed with cancer, so less than 12 weeks from diagnosis. We chose to focus on retinoblastoma and osteosarcoma. And we did this for a few reasons. One is that they both often include appearance-altering surgeries. So for retinoblastoma, that's a cancer that affects the eye, and you often have to take the eye out. So enucleation is often involved. And then osteosarcoma treatment can often involve amputation of an extremity. And we knew from the literature and from clinical care that treatment abandonment was high in these populations, sometimes surrounding those surgeries. Also, retinoblastoma impacts babies and osteosarcoma impacts adolescents. And so that gave us an opportunity to study stigma both in adolescent patients themselves and sort of stigma transference in parents or caregivers of both adolescents and babies. So we interviewed the adolescents, we interviewed their parents, we also interviewed healthcare providers who cared for children with these diagnoses. And most of this was a semi-structured qualitative interview, focused again on that framework I just presented, including the drivers, facilitators, stigma practices, and experiences. But we also, in the parents and adolescents, decided to pilot two tools that had been used in adult oncology populations. One that was specific for chronic illness, which is the SSCI, Social Stigma and Chronic Illness, and one that's the Social Stigma Problem Scale. And so overall, what we found, which is what we had hypothesized, was that there was much more shared. There was this sort of universal outgroup experience of being diagnosed as a child with cancer or having a child diagnosed with cancer that far outweighed the nuances between countries. And so there were some things that we saw only in a couple places. For instance, this idea of sort of witchcraft and traditional beliefs, magical thinking, was prevalent in Zimbabwe and in Guatemala, but less so in Jordan. In Jordan and Guatemala, they talked a lot about stigma at school and media portrayals, and that did not come up as much in Zimbabwe. And in Zimbabwe, for instance, we saw a lot of stigma around radiation therapy that we didn't see in the other two locations. But really, overall, there were many more similarities in terms of this experience, which included isolation, shame, denial, this thought that your child was not whole if they had cancer, and the practices in the community, including stereotypes and stigmatizing behavior. And we saw all of this lead to similar outcomes in these three sites: delayed diagnosis, abandonment, psychosocial distress. And then thinking about drivers, there was also a lot of overlap there. Fatalism, so the idea that cancer is not curable, that you'll die anyway, so why treat it? Contagion, the thought that cancer is contagious, and so stigma around that. Blame, the idea that your child has cancer because of something you did. And so lots of limited or misinformation driving stigma. We created, sort of reworked that health stigma and discrimination framework for pediatric cancer. And here you can see focused on the drivers, but also the mitigators and potential interventions that came up. And what we really saw was quite a bit of resilience and this desire to focus not only on those potential negative outcomes, but also the positive outcomes that came from overcoming stigma, including resilience and adherence to therapy. And so we included those in our revised framework as well. As we tried to pilot these tools, we had to make extensive adaptations. And some of those adaptations were related to the population. So trying to use a tool that had been used in adults for a pediatric population was difficult. But many of those adaptations were also contextual. So for instance, there was an item about going to the movies on one of these scales, and in at least 2 out of the 3 sites, they said children, really, even adolescents, don't go to the movies. They don't have that opportunity. It's not a social setting they're in. We have to change that. And so we ended up changing these tools quite a bit. Ultimately, the domain-specific and the overall scores were much higher than we expected, much higher than had been reported for these scales in other literature. And what we don't know is whether that's because we changed the scale so much and ruined their validity that we can't expect the same types of numbers, or whether that's really because stigma in this population is just so high. But the other thing we saw with the adolescents and parents who we interviewed in dyads was that there was quite a bit of discordance. And so this slide shows that on both scales, you can see that the patients and the parents scored very differently. And so on the SSP, almost all of the patients rated their stigma higher than their parents had. And the SSCI was a little bit different in different sites. So this led us to believe that we really needed to develop a tool to assess stigma for pediatric cancer, because if you cannot measure something, you cannot change it. And so you saw with financial hardship that we've been doing some tool development, and we have ended up doing that with our stigma work as well. And so this new study is called RESPECT, and these are the aims. Because of that initial study showing us the discordance, we really decided we needed two tools, because we want to assess stigma as it relates to the patient, but we know that the parents still have quite a bit to do with outcomes, decisions around accepting therapy. Sometimes they're the only decision maker, and so we have to assess their stigma as well. So two clinical tools, one at the level of the patient and one at the level of the caregiver, to identify and measure stigma. And then we really wanted to continue to do this in culturally diverse global settings, because again, so many of those adaptations were because the tool wasn't developed in a context appropriate setting. So we've been doing this in the US, in Guatemala, and in Jordan. Once again, we started with a literature search, partially because we were just hoping there was already a tool out there. There was not, but we did include in that literature search, we found over 750 tools to measure stigma. Only 3% have been used in any pediatric population and none in pediatric cancer. We did pull items just like we did for material hardship, and then brainstormed some new concepts with members of our Global Alliance. We had folks rate importance, clarity, and sort the items, which is what we're doing for financial hardship now, included an expert panel review, and then did this process of cognitive debriefing. And so what we do there is we take the tools and we ask the questions, but instead of having the patients or the caregivers answer the questions, we then ask them probes about how they understood the question to make sure that they are understanding the same question we think we're asking. And so we've done this at St. Jude, and we're doing it now at our site in Jordan and in Guatemala. And we hope soon to have complete tools for piloting. And so again, the Kids Can Shine tool is the patient level. So for patients 8 to 18 from diagnosis through survivorship. And then there's a caregiver tool. And you can see that there are 6 and 5 domains respectively, and then some demographic questions. So now that we are going to have tools to measure stigma, we also want to begin to do something about it. And our literature search also demonstrated very few effective interventions, only 2 effective in pediatrics and none in pediatric cancer. So the next study, we will be using our tools in a cross-sectional analysis using 13 sites globally, and then co-designing an intervention to improve stigma and testing the preliminary efficacy, feasibility, and appropriateness of that intervention in a cluster randomized controlled trial design. So now I'll move briefly to communication. Again, we know communication is central to pediatric cancer care. The literature demonstrates it increases hope, trust, peace of mind, and a sense of purpose, that it enables decision-making, and that poor communication contributes to regret. But once again, most of this has been done in high-income contexts. And so we know in low and middle-income countries, there are other barriers. Physicians do not receive training in communication, and we don't know what the needs are of this population or the impact of culture and context. So once again, we don't really know if what we've learned in high-income settings can be applied. So this is a patient-centered communication model. It was again initially developed in adult oncology. It was developed from investigators at the National Cancer Institute in the US. It was then adapted from work also done in the US for pediatric cancer. And so we went from 6 functions in the adult model to 8 functions in the pediatric model. And so you can see those functions there. And we also have been looking at this globally. And so at the same time that it was being adapted for pediatric oncology in the US, we were looking at it in Guatemala, in Pakistan, and now in the Philippines. Because if you look at these functions, things like building relationships, exchanging information, we, with global partners, posited that these would apply in very different settings. But again, we wanted to do the work to demonstrate that. And what we found was indeed all functions were relevant. We did find trust to sort of get pulled out in these low income contexts as really central. It had previously been described as part of the other functions, but it came out as its own function in our work. And we learned that the family's pre-existing beliefs were impacted by the diagnostic process, so by communication at diagnosis. And there were determinants influencing communication at the level of the institution, the clinician, the patient, and the family. And in some of our quantitative work in Guatemala, you can see on the left, that's the functional model. And in teal, you see how many caregivers prioritized those functions and how many said they experienced them. And so almost all of the established functions were highly prioritized, but there were pretty big gaps in their experiences. And overall, we found that just like families in the US, families in Guatemala really wanted all the details of their child's cancer, including chance of cure and late effects. But only 67% said they got the information they thought was important without asking. And the vast majority had questions they wanted to ask, but said they held back. And this also highlighted families at high risk of poor information exchange, which in this population included families of patients with solid tumors. We did the same thing in Pakistan, and you can see once again, all 8 functions were highly relevant and prioritized, but even bigger gaps in their experiences. Once again, all families wanted the information, but this time only 37.5% said they got what they thought was important without asking, and even more held back questions. And you can see here that in Pakistan, there were caregivers who wanted all the details all the time, and then caregivers who said they really didn't want all the details all the time. And we also asked when they wanted these details, and pretty split in terms of some caregivers wanting it all up front, some wanting it over time, and some it being situation dependent. So again, the importance of assessing caregiver preference around information exchange. We've started this work in the Philippines as well, but don't yet have the data to present. So we've done this deep dive in these 3, really it's going to be 5 centers overall, but 3 countries. And that has helped us highlight what's universal and what might be context dependent. But we've now really tried to move the work globally. And so we've completed 65 interviews with survivors, caregivers, and clinicians asking about priorities for high quality cancer communication. Because right now we do not have any measures of communication. Even in the US, even at St. Jude, we don't measure communication. So when we change things and we think we're improving our communication strategies, we don't really know if that's true. And so we're trying to establish indicators for patient-centered communication. And we've done that through these interviews. And then last November, we had a workshop here at St. Jude where 46 participants from all over the world came together. And we presented some of the qualitative data, and they helped us transform those into indicators, which will now go through what we call a modified Delphi process. And our hope is soon we'll have preliminary indicators. And so then just very briefly, I'm going to talk about care coordination as a potential intervention to bring some of this together. And specifically, I'm going to talk about navigation. And so patient navigation programs have been well established in oncology. They were first established in breast cancer. And you see navigator programs in which the navigator is a healthcare worker, a layperson, community members, or nurses. But in pediatrics, there's also a lot of literature supporting parental engagement. And on the adult side and in other pediatric subspecialties, we've seen patient navigator programs where you have peer navigators. So parents, caregivers, or in the adult world, peers, survivors that have been trained to help with navigation. And so this has also been used in neonatology, but we haven't seen it in pediatric oncology. And so at St. Jude and through our affiliate network, we thought about using navigation for clinical trial enrollment because we know pediatric cancer is a rare disease that's dependent on clinical trials. And there are individual benefits to patients enrolled on trials as well as the overall scientific advancement. That said, there are huge disparities because there are gaps in who enrolls in a clinical trial, and that limits our generalizability and access to novel therapies. And so we've done this through our St. Jude affiliate network because we've seen differences between different affiliates. As you all may be aware, there are 8 affiliates associated with St. Jude, from Tulsa to Charlotte to Peoria to Shreveport, and there are differences in terms of who's enrolling in clinical trials. Part of being an affiliate is that all of those patients have access to clinical trials, but we've seen differences in enrollment, and we looked at the systems level and the healthcare provider level, but recently we've really started to look at the caregiver level. And so this study is called You Decide. And I won't spend as much time on the first 2 aims, but I just wanted to let you know that we do have these first 2 aims that are survey-based, and then with some qualitative interviews to really look at, again, the caregiver perspective, the family perspective about the decision to enroll in a clinical trial. And so we're looking at sociodemographic characteristics, but also decision-making factors, trial-related attitudes, and we'll eventually be comparing families who make the decision to enroll versus those who decline enrollment to see if there are differences there. But the third aim is what I want to focus on, which is our navigator program. And so we're piloting a navigator program, training parents as navigators. And so the participants for this program are newly diagnosed parents or legally authorized representatives who have a child eligible for a clinical trial. Whether or not they enroll, they're eligible for our study. And the navigators, which I'll get to in the next slide, are parents of children who are formally diagnosed. And the interactions, again, this is a really intensive upfront navigator program because it is focused around that clinical trial enrollment. So we've set up 2 interactions, one in the first 3 weeks and one in the second 3 weeks, focused on decision making and concerns around trial, confusions around elements of the clinical trial. And then the navigators are obviously not the experts in all the clinical trials, but are making referrals to help families get the information they need. So we've recruited 1 to 2 parent navigators at each affiliate site. These navigators have to meet all of our St. Jude volunteer staff requirements and have a child or adolescent at least 1 year from diagnosis and active therapy, and have resources to commit to 6 months of the program. They got interviewed by the study team, and then we have a training program that is both independent asynchronous and then a live synchronous session. And I think I've gone over the participant eligibility. And so we currently are enrolling families. I think we've enrolled about 6 families to date. There's been huge enthusiasm for the project. I don't yet have that feasibility and acceptability data, but hope to soon. And we've been thinking about how we can use this globally. And so we, again, know that a lot of our partner sites are using navigator programs to mitigate barriers, but doing it in a variety of ways. And a lot of it has been focused, again, on treatment abandonment. Once again, there's really limited literature or evidence base, and that has made funding these programs and sustaining these programs difficult. And so we have a new study in which we're trying to describe the landscape of patient navigation globally and adapt existing materials. Partners like the American Cancer Society have materials for navigation in adult oncology. And then CCI is Childhood Cancer International, and ALSAC is a St. Jude funding organization that partners with foundations globally. And so, again, we know there are resources out there. And so we're trying to bring all of these things together to once again create a toolkit for global patient navigation, which we'll then pilot. And so this is our plan for this mixed method study. Again, it involves a literature review of existing materials, and then some co-design to hopefully create an intervention that once again will be globally applicable and locally adaptable, and that will pilot. And these are just our anticipated outputs, that toolkit again, and a plan for global scale up. And so I hope that now I've started to demonstrate how many different components there might be to something like treatment abandonment, how these factors at the patient and community and health systems level interact, how little work there has been done on all of these different factors, and how intensive and deep the work is, and how we've really needed to begin with foundational exploratory work and doing things like developing ways to even measure these concepts before we can get to intervention. So in a lot of ways, it's the next 5, 10 years that hopefully we'll really be able to delve into interventional work and make changes. And again, our focus today, because it's my focus, has been pediatric cancer. But I hope that those of you involved in different work have seen ways in which this could potentially apply to the work you do. This is obviously the work of a village. And so first and foremost, we have to acknowledge all of the patients and families for whom we do this work and who have dedicated time and energy to participating in our co-design, to being participants in our research studies, the many, many, many teams we work with globally to conduct this work, and of course, a few of our funders listed there. So I thank you again so much for your time. Here are some of my references. And if it's appropriate and we have the 5 minutes, happy to take a question or two. Yeah, I see a hand raised. Natasha?
Hi, I just really wanted to say thank you for the work that you and your team are doing. I think when we think about the care that we provide to patients, ensuring that we're communicating in effective ways and providing the highest quality care to patients who have different goals and different situations and different opportunities and different access and all kinds of different parts of the world, but not forgetting that everyone still has a fundamental definition of health and wellness and desire to have that for themselves and their family members. So it's important work. And I, as I said, just wanted to say thank you.
Yeah, I appreciate it. And I think one of the things we often say is what's good for the world is good for St. Jude, and what's good for St. Jude is good for the world. So I hope the other thing that I've been able to demonstrate is how much of this work we do really in collaboration with global partners and locally, because again, stigma was not a thing we've been really studying here at St. Jude. Navigation is new here. And so I think as we maybe demonstrated in our stigma study, people are more alike than different the world over, although there are, of course, cultural nuances that really impact care. And so thinking about wherever you practice, how this might apply at a local and systems level, I hope will be helpful. Great. Well, thank you all for your time this morning. Oh, sorry, Jenny, did you come on camera?
I just wanted to say thank you, Dr. Graetz, for joining us and sharing the global perspective of the challenges that we have. And we always appreciate the great work of St. Jude's. So thank you. And we hope to have you back sometime in the future if you're able to, as your research continues. And so thank you once again.
Thank you all. Thanks for your time this morning. Take care. Have a great day.
Thank you so much.